I have the honor to invite Professor Dr. Tarek Eid, who is going to discuss with us the never-ending debate between cataract and glaucoma when they coexist. Dr. Tarek, please. Dr. Alaa.
ألف شكر دكتور نادر، وشكرا للجنة المنظمة على اليوم الجميل والمؤتمر الجميل إن شاء الله. يمكن المحاضرة بتاعتنا على الكوموربيديتي بتاع الكاتراكت والجلوكوما مع بعض في المريض بتاع الأوفثالمولوجي. و I want to يعني الأوتلاين بتاع المحاضرة بتاعتنا عايزين نعرف what's comorbidity means، وايه الكوموربيديتي اللي موجوده في الاوفثالمولوجي ان جنرال، وبعدين بقى الكوموربيديتي بتاعت الكاتراكت والجلوكوما، البريفالنس، ريسك اوف ديفلوبمنت، ريسك اوف بروجريشن، ايه التريتمنت ستراتيجيز للكو-existing cataract وجلوكوما، and what glaucoma procedure we can choose to combine with the cataract surgery. Comorbidity in medicine is the simultaneous existence of two or more illnesses in one person, whether pathogenetically related to each other or coexisting independently. وعندنا common examples of comorbid disorders زي diabetes, hypertension and dyslipidemia, obesity, chronic heart disease or obstructive pulmonary disorders. وممكن كمان يبقى comorbidity بين physical و mental illness، و it can overlap with some complications of other disease. The presence of comorbid disorders affects clinical implications, diagnosis, prognosis, and treatment plans and outcomes. Also, it increases patients' feeling of illness and disability. It affects quality of life and hinders rehabilitation. It increases complications of surgical interventions and increases chances of treatment failure. How about comorbidity in ophthalmology? This when two or more combinations of eye or systemic disorders exist simultaneously, regardless of their etiopathogenic relationship. Examples: ocular comorbidity. الcommon examples اللي عندنا glaucoma and cataract, or cataract and refractive error, أو glaucoma and dry eye disease, or cataract and age-related macular degeneration. Also uveitis, cataract and glaucoma, or cataract, glaucoma, and retinal vein occlusion. Systemic disorders combined with ocular disorders، هنلاقي diabetes ممكن معاها cataract وجلوكوما، هنلاقي الهايبرتنشن ممكن يبقى معاها vein occlusion and ion، autoimmune diseases ومعاها uveitis، age-related macular degeneration معاها glaucoma ومعاها neurodegenerative disorders، dry eye disease ومعاها autoimmune disorders. نيجي بقى للايه الكوموربيديتي اوف cataract and glaucoma. What's the prevalence? It's very common in old age because we have senile cataract and senile glaucoma. Also, it can complicate each other. Complicate one cause, like ocular trauma can cause cataract and glaucoma, or intraocular inflammation can produce cataract and glaucoma. It can be a side effect of prolonged steroid treatment, or part of congenital anomaly, أو systemic syndromes like pseudoexfoliation, Marfan, أو mucopolysaccharidosis and Down syndrome. What is the risk of development? It's common related to aging as primary disease, or it can one pathology may lead to the other. زي ما سمعنا من شوية natural lens thickening can produce in a predisposed eye can cause glaucoma في النانوفثالmic eye, phecomorphic glaucoma, phecolytic, cataractogenic glaucomatous medications, cataract progression after glaucoma surgery, or glaucoma complicating cataract surgery. What's the risk of progression? أولا فكرة إن إحنا we can difficult to differentiate the visual deterioration, is it from the cataract or can be also additional glaucoma affection. The visual prognosis after cataract removal may be difficult in a glaucoma patient. Cataract progression increases after glaucoma surgical intervention, and IOP control may be jeopardized after cataract extraction. Also, outcome of glaucoma surgery may be less than optimum in a previously operated eye. What are the treatment challenges? As we heard from the previous talks, cataract surgery may be more complex in an eye with previous glaucoma operation or prolonged anti-glaucoma treatment. IOL calculation may be less than accurate in hypotenuse eye after glaucoma surgery because of high bleb, shallow AC, or high astigmatism. Toric IOL may not be appropriate in treating astigmatism post-trab. Multifocal and trifocal IOLs may be avoided with moderate to severe glaucoma because of reduced contrast sensitivity. Also, YAG laser capsulotomy can affect IOP control in a glaucoma patient. So, what are the treatment strategies we think about? First, we have to ask ourselves, is glaucoma medically controlled? And is glaucoma course predictable? And which contributes more to the visual loss? Is cataract surgery alone is enough? Or does sequential surgery provide the optimum management? And if sequential, we start glaucoma surgery first or cataract surgery first? And when combined surgery is done, which glaucoma procedure adds the best IOP control with less complications? Should we choose a penetrating surgery, or ab externo non-penetrating surgery, or ab interno angle surgery? So let us see if we are going with sequential cataract surgery for a patient who has cataract and glaucoma, and we start with cataract surgery first. We do it in a visually significant cataract with mild to moderately controlled glaucoma. And actually this is gaining more acceptance because of the advances in cataract surgery and IOLs, and also advances in medical treatment of glaucoma. It has several advantages. First, low surgical risks compared to glaucoma surgery. Short recovery, better visual outcome, good effect on IOP. Removal of the bulky lens deepens the angle and widens the anterior chamber. Decrease iris chafing and pigment release, and remove the source of pseudoexfoliative material. And also it can let us with virgin conjunctiva for subsequent glaucoma surgery. How about if we do glaucoma surgery first? If we have to go for glaucoma control first before the cataract removal, it gives us better control of IOP, because if the patient has high glaucoma morbidity, and also better outcome in phakic than in pseudophakic eye. The trap is known to have good effect in the phakic eye than pseudophakic eye, and usually preferred in advanced cases of glaucoma for better control of IOP first. Disadvantage of this approach may increase cataract progression, and usually we have early post-operative instability in vision and refraction. Patient satisfaction is low. Increased risk of surgical complications with subsequent cataract surgery, and filtering place may be compromised. How about if we can do combined surgery? Combined glaucoma and cataract surgery in the same event. First, two pathologies are hit in one setting with one admission, one surgery, and one recovery. It avoids pressure spikes that can happen after cataract surgery in a glaucoma patient. Avoid hazardous effects of the subsequent surgery. Mitomycin improves success of combined surgery and minimize the incidence of BCO. And newer glaucoma surgeries now have better outcome when combined with the cataract surgery. It has some disadvantages like increased surgical risks, longer surgery time, longer visual rehabilitation. The IOP reduction and the blip function may be less than after trap alone. And also the predictability of the refractive outcome may be affected by changes in AC depth and axial length. So if we are going to do combined glaucoma surgery, which glaucoma procedure should be combined with the phaco for the comorbid cataract and glaucoma patient? Let us see, for the mild glaucoma patient, we may think of either phaco eye stent for mild glaucoma, or phaco goniotomy, or goniosaniculisis, or maybe a goniectomy like Bang technique. This has combined phaco eye stent in the your right side of the screen, where we do remove the phaco first, and then we put the surgical gonio prism and the eye stent. We inject two eye stents in the trabecular meshwork. While in the other screen, we do what's called the Bang technique with a pent insulin needle, and do exactly the same like a hook, double blade, to remove, excise part of the trabecular meshwork. So we do this actually part of the mixed procedures for mild glaucoma cases. For moderate glaucoma cases, we can go for either phaco-GAT for moderate glaucoma, or we can do phaco-canaloplasty. We'll do combined procedures, phaco procedure as a routine, and for the phaco-GAT in your right side, we'll go with the gonioprism and I'm sorry, it went rapidly. Okay, so this, sorry, the slide should start. Okay, anyhow, for advanced cases, we'll go with phaco-trab, either phaco-trab separate site approach or same site approach for the advanced cases. So here is the videos for the separate site, and the advantage of separate site is that we go for clear cornea phaco on temporally, and then switch to superiorly to go for the trab. While with the same site approach, we stay on the superiorly and go with the phaco from under the scleral flap of the trabeculectomy. So if we need to answer the question which glaucoma procedure should be combined with the phaco for the combined cataract and open angle glaucoma patient, here are the chances, the procedures that we have. Either do phaco alone, or phaco MIGS, or bang, or phaco canaloplasty, or phaco GAT, phaco trab, or trab alone. If we have a patient with early primary open angle glaucoma, maybe phaco alone or phaco eye stent is enough for this patient. We don't need to do phaco GAT or phaco canaloplasty or phaco trab. But if a patient with moderate primary open angle glaucoma, maybe phaco alone will not give us the target pressure. Also, phaco stent is not appropriate, but phaco canaloplasty or phaco GAT can be appropriate for this patient. If a patient with advanced glaucoma, the phaco alone or phaco MIGS or phaco canaloplasty or phaco GAT may not be enough to reach the target pressure of this patient, so we can go for phaco trab, or even we can start with trab alone for these advanced cases. If a patient with angle closure glaucoma, if we apply the same for these patients, if a patient with primary angle closure suspect, I think phaco alone is enough for this patient. If it's mild angle closure glaucoma or PAC, then we can go for either phaco alone or phaco MIGS or phaco eye stent or phaco bags, bank, or phaco goniosyncytial. But with moderate glaucoma, maybe phaco alone may not be enough, but phaco goniosyncytial or even phaco trab can be quite enough. Some patients may go for phaco GAT. If advanced glaucoma, we will go direct for phaco trab, not trab alone, not phaco GAT, not phaco GSL. I think this concludes our talk, and thank you very much.
Thank you very, very much for an excellent wrap-up of the topic. Just one very simple question. What's your routine post-operative regimen or care for combined phaco-trab, given that there is a phaco with the trab?
Can we start from the beginning?
Beginning, of course. Thank you very much for the excellent wrap-up.
Start the question from the beginning.
What is your routine? What is your routine post-operative care for combined phaco-trabs, given that there is a phaco procedure in addition to the trab, other than the trab alone?
Okay, for phaco trab, the surgical, the post-operative care.
Exactly, sir.
The post-operative care should start while you are operating. The patient with the phaco trab, be cautious with the patient. At the end of the procedure, try to dilate the pupil. Don't leave it closed. try to reform the AC. Make sure you titrate your filtration. You don't have any leaks, and your AC is formed well. You can adjust even the flow through the trap. So make sure that you don't have any turbulence post-operatively. Once you finish, you leave the pupil dilated.
sir.
Hmm?
No retained OVD. You don't leave any. Leave, sir, any OVD at the end of
No,
the combined.
no. I
Completely
don't
no.
leave any OVD in the AC.
Okay.
I keep the AC formed with saline.
Okay.
And I make sure that the flow is minimum.
Okay.
I can just press with the sponge to make sure that it can elevate the blip to test the leakage if there is any the water tightness of the conjunctiva.
Sure.
But I keep the AC deep, pupil dilated, and make sure there is some flow, minimum flow, but no more. And after that, the routine with the patient, I give the patient steroids every 2 hours, antibiotics every 2 hours, cycloplegics. With these patients, I give non-steroidal anti-inflammatory, and I even give them the non-steroidal a longer time than routine phaco. I instruct the patients very carefully about, especially bed rest, very important for these patients. No massage. I'll do massage myself. I don't tell the patient to do massage. I do it myself if I see the pressure is high, especially in the first week. Maybe after 1 week, I can ask the patient, I teach him how to do massage.
Okay.
I don't do laser suture lysis before 2 weeks.
2 weeks.
This is also important. The turbulence of the AC after 1 week, sometimes you get pressure high after 1 week and you say, I will remove 1 stitch. It's not, I saw many complications after this.
Sure.
That's all. After that, the routine, I keep the pupil dilated. For primary open angle glaucoma, I keep the pupil dilated for 3 days. And then I stop the cycloplegic. But for angle closure glaucoma, I keep 1 week full. 1 week cycloplegic.
Sure.
I keep it.
Okay. So the critical period is the first 1 to 2 weeks.
Hmm.
It is the first 1 to 2 weeks.
What?
Period is the first 1 to 2 weeks
Yes,
after.
exactly.
Thank you. Thank you very, very much,
Okay.
sir. Thank you.
You're
So, with this, we conclude our session. On behalf of the audience, I would like to thank our esteemed professors for excellent and informative talks. Thank you very, very much.